Hi guys, this is Dr. T and welcome to Clinical Medicine with Dr. T. So guys, let us finish this topic on fluid resuscitation. So there's just more small details that or small info that I want to share with you that is left. Sorry guys that we have to even get to part 4. It's a complex topic, it's a very crucial topic, it's a very important topic. So that's why we had to make sure that we do justice when we are covering it. Okay, so guys, we've spoken about, okay, so when you have a kid that you want to give fluids to, this is what you're going to be doing. You will decide if the kid is in shock. So you will decide if you need to do resuscitation or if you need to do rehydration. So when the kid is in shock, like we said, that you want to give them an isotonic solution, an isotonic fluid. And we've explained why we need an isotonic solution. So the fluid of choice is normal saline or Ringer's lactate. And remember, this is mainly aimed at increasing rapidly increasing intravascular volume, because the kid is in shock. So we want to do it rapidly, very quick. So that's what we want to do. And the dose of the fluid that is given is sort of like standardized. If they're in shock, it's supposed to be 20 mils per kg as a bolus. When we say bolus, we don't mean that you calculate this fluid and then you let it run and take its own time. No, you take a syringe, you draw the amount of fluid that you want using this 20 mils per kg. If it's a kid that is 3 kgs, it's going to be 20 times 3, that's 60 mils. So you want that 60 mils to go straight into the veins. So that's 20 mils. And then, because what you want to take them out of shock. You want to take them out of shock. So the 20 mils per kg bolus, you are allowed to repeat it. You can repeat it. You can do it for the first time, second time, for the third time. When you get to a point whereby you have given between 60 mils per kg and 80 mils per kg, but there is no improvement, then you should start to query if you are dealing with another type of shock, which can be septic shock, which can be cardiogenic shock, or even hemorrhagic. Because you thought it's hypovolemic shock, maybe you might be dealing with another type of shock. If you give it for the first time, you wait for about, some say 2 to 3 to 5 minutes and see if the kid is improving clinically. What would you see to say that the kid is improving clinically? First of all, you want to check if they are starting to wake up, because they will come in lethargic, they'll come in with their eyes closed or half open or partially opened. Once they start to open their eyes, they start to be aware of their environment, their capillary field improves, their eyes improve, they start to look now, and they start to be aware of the environment, the blood pressure improves, pulse improves. Then you can say, okay, the kid is becoming better, is coming back to life, and then you can stop the boluses. But if none of that is happening, you do it up until you get to a point where you say, okay, what am I missing? Let's say, for argument's sake, you are able to take them out of shock, which is what happens most of the times. They come out of shock. Remember, obviously, when you've got a child that has been having vomiting and diarrhea, and then they've got some electrolyte imbalances, they might not just wake up like that. because of the electrolyte imbalances, especially if they have hypokalemia. So once they are out of shock, now you calculate their fluid, you take them to the rehydration, because they are out of resus now. So you stop giving these kind of fluids. You take them to the rehydration side where you use half DD there. And rehydration is done in two ways. You want to calculate fluid for maintenance and also for ongoing losses. Ongoing losses. So maintenance fluid, let me give you guys this example to help you to understand this. Unfortunately, I'm weighing about 80 kgs. So if my maintenance fluid is about, let's say my maintenance fluid, I need about 1.5 liters of water per day. That's what maintains me. For example. So if I need about 1.5 liters of water per day, that's what maintains me. So that 1.5 liters for me is crucial for my metabolic activities to go on without disturbances. Remember, water is very important for chemical reactions in the body and other things as well. So if my maintenance is 1.5 liters per day, I need that 1.5 liters, whether I need it, whether I'm dehydrated, whether I'm in shock, I need it. Whether I'm euvolemic, I'm normal, I need it. It's what maintains me. I need that 1.5. If now this day I've got diarrhea and I lose about 500 mils, it means that if I continue to drink 1.5 liters and yet I lose 500 mils, then I will be left with about 1 liter and I will have about 500 mils deficit. And this 1 liter is not my maintenance fluid. My maintenance fluid is 1.5. So I'm behind with fluids. So what I need to do is, if my maintenance fluid is 1.5 liters per day and I lose 500 mils, it means I must increase my maintenance fluid to be 2000. It means I must increase to be 2000 mils. So it means now basically is that if I lose 500 mils, then I must take more water to cater for this loss, so that if I take 2000 mils of water and I lose 500 mils of water, I'm still left with my 1.5 liters of water, so that I can continue to be metabolically okay. This is why I gave you that kind of a scenario. I wanted you to understand maintenance and ongoing losses. So with the kiddies, maintenance fluid for a baby that is less than 1 year, it's 100 mils. Sorry, it's 120 mils per kg in 24 hours. Maintenance fluid for a baby that is between 1 and 2 years, theirs is 100 mils per kg in 24 hours. The one that is more than 3 years is 85 mils per kg per 24 hours. This is very, very important, because if a baby is 4 years and you give them 120 mils per kg per 24 hours, they will be overhydrated, because that's not their maintenance fluid according to these guidelines, right? So, and then ongoing losses, 50 mils per kg per 24 hours. So now, which means for someone who's having ongoing losses, you take their maintenance, you combine it with their ongoing, and then that's the fluid that they need to get in 24 hours. So if, let's say, we have a kiddie that is 3 kgs, for instance, they've got diarrhea, and this kiddie is 9 months, it means that they fall in this category. So their fluid will be 120 mils multiplied by 3 kgs divided by 24, which is 360 mils divided by 24, whatever that is. And then this side is going to be 50 multiplied by 3 divided by 24, which is going to be 150 divided by 24. Now, for argument's sake, guys, I'm not a mathematician. So for argument's sake, let's say 360 divided by 24, for some reason, is 6 mils. This is their maintenance fluid, but we don't have ongoing, we have not catered for ongoing losses. So which means now, let's go and check what is their ongoing fluid loss on the other side. So if we calculate this and we find out that, okay, this is 2 mils, that's their ongoing losses. So we are going to add these two numbers. So their fluid, their regulator should run at 8 mils. This is like a very small, guys. So it's going to run at like 8 mils per hour. That will be their their fluid that they will be receiving per hour. Not necessarily for 24 hours, because in 4 hours you're gonna come and review this baby and see if you are improving, or if the child is the baby is getting better or is getting worse, or what is happening. So when you come back and see that the child is becoming better and better and better, so what you want to do now, if the baby is becoming better and then they are showing eagerness to drink, they are awake, they want to drink, what you want to do, you want to push them to a point where they start taking oral fluids, because no one should be on an IV. Everyone should be taking their fluids orally. But when they are sick like this, people need IV. But so what you want to wean them off from the IV fluid. So we said that this one is receiving 8 mils per hour. So this is the total fluid that they must be receiving. So what you're going to do is going to say, oh, okay, some doctors would say, even if I give this baby 8 mils per hour, if they want to drink, give them, it's okay. But some would say, don't give them oral. If the child is vomiting, obviously they shouldn't be on oral if they are vomiting, because they will aspirate. So meaning you shouldn't encourage oral. But if they can take oral, you can give them oral, and then look at, and when you recheck again in 4 hours, you see, okay, they are becoming they have improved, they are becoming euvolemic. Now you can start to say to yourself, oh, okay, let me start them on oral. If you're on oral, let me start them on oral and say, okay, of these 8 meals, let's make 4 meals. I'm just making an example, guys. If you do these numbers, you'll find that this 8 meals is much more than that. You say to yourself, oh, okay, out of these 8 meals, let me give them 50-50. Let me say, okay, 4 meals, they should take it orally. And then the other 4 meals, I'll still give it IV. Then you come again, you say, okay, this child is doing well. Let me decrease IV and make it 2 meals now, and make this other side to be 6 meals, up until you get to a point whereby IV is 0 and oral is 100%. So that's the plan. So guys, I don't know if I'm leaving anything behind. Obviously, like we said, that what you want to do is that after doing your research, you want to make sure that this kiddie doesn't have any red flags. They come in vomiting. You want to make sure that they don't have red flags. Like a kid who's vomiting with abdominal distension, that abdominal distension is a red flag. Or they've got right iliac fossa tenderness. That right iliac fossa tenderness is a red flag, because they might be having appendicitis, or maybe they might be having projectile vomiting or bilious vomiting, or they might be having a mucoid stool or a bloody stool like dysentery. So those are red flags. That kid is sick. Or they are having electrolyte imbalances. When they've got electrolyte imbalances, that's a red flag, because it means this person has been having this diarrhea, or it's like a very so it's very serious for it to cause electrolyte imbalance. It's very, very serious. And obviously you will take a good history, examine them, and look for those red flags. Or maybe you're gonna just find otitis media, or you're gonna find a UTI, or maybe they are vomiting and diarrhea is just due to rotavirus infection or viral infections for that matter. So, and then you decide, okay, what are your investigations that you're gonna be doing? But most of the people, they do a CRP, they do a FBC, some do a white cell count only, and then some will do a chest X-ray, some will, obviously you need an ABG, so things like that. So guys, I believe that we have covered the important things. We've covered a lot of things that will help us to deal with this kind of patients better. So guys, that's it.